Strabismus and sphynx anesthesia. So it's the Mills alignment of visual axis. Visual axis is a line of vision extending from the point of fixation to the fovea, and anatomical axis the line passing from the posterior pole through the center of the cornea. So you can see there are two lines. This is the anatomical axis. This is the visual or optic axis. So there is a small angle passed by that. This is called the angle of kappa. This is the angle formed. This is the other view where you can see the visual axis lies on the lateral to the optic nerve on the fovea. So this is the normal angle. It is about 5 degrees positive. Then there are various terminologies. Of course, the word phoria means hidden and trophia means manifest. So there are heterotrophia, which is latent skin, phoria, which is latent skin, trophia, manifest skin, like that. Of course, just to know that this is called esotropia, which means latent skin turning on the eyes. This is exotropia, which is manifest inward turning of the eyes, and hypotrophia, hypertrophia when looking down and up. So these are some of the terminologies. Just in case they ask you, you must be able to make that instead of saying convergent, divergent skin. And extraocular muscles, you can classify them into horizontal muscles, which are medial rectus and lateral rectus, vertical muscles, which is superior and inferior, and oblique muscles, which are superior and inferior. So totally 6 muscles, of which 2 are horizontal, 2 are vertical, and 2 are oblique. So these extraocular muscles, by their attachment, they form the cone, something like a cone like this, and you can inject the local anesthetic inside this cone or outside this cone. That is the important of that. And ocular movements, there are movements of abduction, adduction, superinduction, various angles is there. This is not very important for us, just for some knowledge. And we must ask past history of any head injury, CNS infection, CNS surgery, influenza, measles, or history of seizures, prematurity or respiratory distress or birth, muscle weakness, myopathy, or endocrine disorders. These are all the past history of the child, and any anesthetic exposure in the past, any blackouts or sudden unconsciousness, whether the patient is on any beta agonist drugs like for some other cardiac conditions, and syndromes that can be associated or Crouzons or Apers, muscular disorders with potential malignant hyperthermia occur in central core disease, myotonia congenita, Duchenne's muscular dystrophy, and other congenital anomalies like autism, common problems like asthma, recent LRA, epilepsy, all these questions you could have. And family history of any exposure to anesthesia and history suggestive of malignant hyperthermia is very important. Challenges in this are all problems common to pediatric anesthesia, separation anxiety, which can be managed by oral pill medication or the parent accompanying the child. NPO can cause irritability, so you can give clear fluids up to 2 hours. Airway differences, help from an experienced person will help you to manage the airway. So this is the oral ray tube which is preferred, or you can use supraglottic airways, but this requires more experience on the part of the anesthesiologist because intraoperatively getting an approach to airway will be problematic. And IV access difficulty can be managed by EMLA cream application. And this is the way the child will look if he has a convergent stent like this. After surgery, you can see the cornea in central posture. Surgery problems, risk of MH, high incidence of post-op nausea and vomiting, likelihood of oculocardiac reflex. So the solution for that is avoid succinylcholine and halothane, IV lignocaine, and the low dose ondansetron, dexamethasone for post-operative nausea vomiting. This lidocaine in local will also help in reducing the OCR. And induction technique can be either the inhalation or intravenous. Maintenance of anesthesia usually with a volatile and air. use of PIVA and will also help to reduce QNV. So you can give propofol infusion and consider atropine 20 microgram IV or glycopyrrolate with if the bradycardia is very severe because of OCR. All routine monitors must be used as per AAGB surgery. Surgery problems are CONV is most common, so we give the diemetics, analgesics, preferably go for NSAIDs and paracetamol and avoid opioids as much as possible. And peribulbar block is effective for analgesic requirement, reduces QNV also. The subtenon block performed intraoperatively by the surgeon can be effective for analgesia during the surgery, but most of the time the surgeons prefer to give a peribulbar block rather than a subtenon block. And technique of peribulbar block, how they give is just for your knowledge, is give outside the muscle cone, needle outside the muscle cone, and 5 ml of 0.5 bupivacaine and 5 ml of lignocaine. This is the adult dose. For children, it will not be this much high. You can manage it with even 3 to 5 ml total of the combination of bupivacaine and lignocaine. And this is how the block. This technique is preferred, giving closer to the lateral canthus, just inferior to the. Go above the inferior margin of the orbit and go at the angle towards the bone so that you don't injure the lobe. And this is a superomedial. This is called inferolateral approach. This is called the superomedial approach. Either one of them can be managed. And the post-duction test is distinguished the paralytic and mechanical restriction. Like in Graves' disease, patients who have a very bulging disease, they may require sometimes oculoplastic resection. So that may cause restriction. So surgeon grasps the sclera near the limbus and tests full range of movement in all quadrants. If it is positive, it is mechanical obstruction. If it is negative, it is called the muscle paralysis. So normally performed under topical anesthesia in the adult, but under GA, wait for 20 to 20 minutes if you are using dexamethasone, because the muscle will still be not responding in the correct way. So non-deportasive muscle relaxants can be given. Intubate and maintain deep inhalation anesthesia till the post-duction test in, then give the muscle relaxant. So full relaxation needed while checking movement and tone restored before the resection insertion. This is the challenge in that. So these are all this is how the post-duction test is done. Pulling and grasping and moving the eyeball in all directions. And this is just to give an idea how they resect the muscle and then reattach it to correct the position of the eyeball. So this is called the bell sign, where the eyeball rolls under the upper eyelid. So you have to, if you deepen the plane, it will come back to normal. And the triggers for OCR are the pressure on the globe, traction on the extraocular muscle, ocular trauma, performing retrobulbar block also sometimes can cause OCR, manipulation of the eyelid by stretching it, ocular pain, hypoxemia, and hypercarbia. So these are all the triggers for OCR. And stimulus route is correctly said, long and short axillary going to the ciliary ganglion. Optimal branch of cranial nerve coming to the gasterial ganglion, going to the sensory nucleus of trigeminus, then connected to the motor nucleus of the vagus, coming through the vagus nerve, attacking on the sinoatrial node. So the type of arrhythmias, not only bradyarrhythmia, it can cause junctional rhythm, atrial ectopic, multivocal PVCs, all these things can happen. The treatment is first to stop surgical manipulation, assess normocapnia and normoxemia, optimize depth of anesthesia, return to normal levels within 20 seconds, no need for any atropine. Arrhythmia, if arrhythmia persists, and there is also a hemodynamic imbalance, then give atropine at the rate of 7 microgram per kg in treatments. Roughly you can give 10 microgram per kg, and lignocaine 1.5 milligram per kg is also added to that. So there is another reflex called ocular respiratory reflex. If the patient is breathing spontaneously because you want to perform the forced suction test and you have not given the relaxant, then it can cause the same route. Afferent is long and short ciliary nerve going to the sensory nucleus, and then efferent through the pneumotaxic center and the middle respiratory center, causing shallow breathing, respiratory rate reduction, or sometimes apnea also. So the oculoemetic reflex, again the same pathway, going to the vestibular nuclei and medial formation in the reticular formation, and close proximity to vomiting center, causing nausea and vomiting. So these are all the pathways for the three reflexes: oculocardiac, oculorespiratory, and oculoemetic. Right. Can we go on